Good afternoon, everyone, and welcome to our 12th annual Canada to Chicago Mentoring Program, or C2MP. I am Stephen Collins. I'm the CEO of Matter, a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. Since we launched in 2015, we've supported more than 1,000 startups from all over the world. We have a suite of services to help them at every stage of development. We also run 6 to 8 startup accelerators every year in partnership with life sciences companies, health systems, payers, associations, foundations. Each one is focused on 5 to 10 companies that's innovating in a particular area of healthcare. We work with dozens of health systems and payers and life sciences companies, helping them collaborate with the right entrepreneurs and innovate more effectively. We are the digital health arm of BARDA's Accelerator Network. BARDA is part of the Health and Human Services Department that's responsible for innovations to improve the United States' resilience in the event of large-scale public health threats. And we host events focused on healthcare innovation that bring people together to be inspired and learn and connect with each other. This C2MP program is our longest standing initiative at Matter. Each year since we opened, we've been honored to work with the Consulate to support terrific Canadian entrepreneurs building next generation technologies. We help them with their US entry and growth strategies, everything from regulatory support to figuring out who's going to pay for their technologies to how to take their solutions to market. In a few minutes, you'll hear from 5 companies who will be presenting not only their solutions, but also what they need help with over the next 6 months of the program. And after each of the presentations, there will be a 10-minute period to ask questions. Please use the Q&A function of Zoom at any time to pose your questions, and we'll go through them during the Q&A period. Thank you to all the mentors who make this program possible. Many of you have participated throughout the entire 12 years, and it's your experience and your time that make this possible. Big thank you as well to the team at the Consulate, Margot McDonald, the Counsel and Senior Trade Commissioner, as well as Julian Rosen and Corey Olashansky, who work very closely with us and work to support the program. The instigator and longtime steward of our relationship with the Consulate is Dr. Steve Gould. He's been a Matter board member since the very beginning. He serves as a consulting director for science ventures at the University of Chicago. He is a mentor for many entrepreneurs. He had a long, distinguished career, chief of surgery at Michael Reese Hospital, founded a company called Northfield Labs, very involved in the kind of civic infrastructure of Chicago, and very committed to advancing entrepreneurship and working with and supporting entrepreneurs. He will be your MC for the program, and he'll join right now. Thank you so much, Steve.
Thanks, Steve. Appreciate the kind words. Welcome, everybody. Delighted that you're here. As Steve said, this is a special program for us at Matter. It's the 12th time we've been doing it. When Matter opened in February of 2015, this event, the C2MP event, was the first formal program, so it's special to us. Before we start the formal program, Steve acknowledged all the support from the key folks at the Consulate. I'd like to introduce Margot McDonald, who is the Consul and Senior Trade Commissioner. She's going to say a few words about the Consulate and the program. Margot came to Chicago last year, and we're delighted to have her here. She and the Consulate and Corey and Julian and the rest of the team have been great partners. Margot, it's a pleasure to introduce you, and we look forward to the program.
Thank you, Steve. Thank you, Stephen. Bonjour tout le monde. Good afternoon. My name indeed is Margot McDonald, and I am the Senior Trade Commissioner at the Consulate General in Chicago. And it is my distinct pleasure to join you virtually today and really to welcome everyone, but especially welcome the 5 Canadian companies selected into the 12th annual. And I say 12, it's really incredible that we have been doing this for 12 years. Stephen just said the longest partnership that you have, and that is a badge of honor. So the 12th annual Canada Chicago Mentoring Program in partnership with PointB and Matter. So we are well past the proof of concept stage. This has lasted 12 years because we truly get results for our companies. And we are extremely grateful for this relationship that we've built with Matter, who is obviously very well known and respected as one of the leading healthcare incubators in North America. And we really, really hope to be doing this another 12 years from now. So as I said, we're thrilled to be able to welcome 5 new Canadian companies to the mix. And congratulations to Alto Technologies, CliniScripts, Cobionix, Focus Technologies, and Vessel Prosthetics, who were selected from a very competitive pool of applicants. And I've been told that this year's cohort is breaking boundaries with stunning innovation in healthcare areas. And I can't wait, just along with you in a few minutes, to hear the pitches. I would say, speaking of pitch, I will take just maybe 1 minute of your time to just pitch some of the great work that my team is doing here. Really, we're a team of the Canadian, an arm of the Canadian government of Canada, and our sole role is to support Canadian companies in being successful in exporting abroad. And we can only do that with partners. And I really see it as like it takes a village approach. And that's exactly what we're doing here. So now to our companies, you are now a part of an even broader village, along with Matter and PointB. And my little advice, if I can give my unsolicited advice, is to take advantage of this village, because I was just saying in a few minutes before, as I got to speak with the companies, I said, use us, that we are here for you to succeed, and we are all vested in your success. So please leverage our connections with the local ecosystem, continue to drive cross-border opportunities across spectrums of innovation, R&D, and commercial functions. And of course, leverage the expertise of the people in this call and in this virtual room of the PointB mentors, including Canada's global executives, for bringing your knowledge and dedication to the Canadian companies. Thank you, PointB mentors, for your support over the years. There's a few more people I just want to quickly thank in this room, and I have a number of very talented staff, a part of the Consulate team. Thank you, Life Sciences Sector Lead Julian Rosen, along with Corey Olashansky and Gina Gonzalez. Thank you, Steve, for your partnership. And thank you for the opportunity to say a few words. I pass it back to you so we can get right into the main show.
Great. Thanks, Margot. Appreciate it. All the folks at the consulate, as they come to Chicago and rotate, have become really friends as well as professional partners, and that has been great. Margot actually has some unique background. She didn't talk about it, but Margot spent some time in Boston and was working at the Broad Institute, that many of you know is one of the outstanding places doing creative life science work. So nice to have that skill in addition to all of your other accomplishments, Margot. Thank you. All right, so we're ready to go in the program, and I want to review the way this will run today. Most of you, the names I recognize are familiar. There'll be 5 companies, and we follow a very defined format. There's a 15-minute time slot for each company. They are asked to give a 5-slide, 5-minute presentation, followed by 10 minutes of Q&A. So that's clearly unusual. They worked hard to work with us. We gave them guidance. Their slide covers the key material to set up the Q&A session, which I think is really the most important. And that's where we get the interaction. The goal is to get each team today 5 mentors, that are ideally suited to help them over the next 6 months accomplish what they would like to get out of this program. So the Q&A is where this interaction happens. They'll highlight the problem they're solving, their solution, what's unique about them, where they are, where they're going, and what their needs are, so that once we dip into the Q&A, we can really dig in. I advise the mentors, so pay attention, audience. Ask a question, keep it concise, don't give a lecture. And I tell the company presenters, give short, concise answers. We'd like to get 5 to 10 questions in for everyone in that 10-minute period, because at the end of that, this is a volunteer. We ask the mentors to volunteer to say, I want to be a mentor on that team. In a perfect world, mentors, you should sign up for all 5 teams. If you do that, if you sign up for more than one, prioritize them. Say number 1, number 2, number 3, number 4. When we do this matching, we will only put you on one team. So we want to have lots and lots of interaction, lots of interest, and the goal is to have the best fit going forward. The companies, Margot just listed the companies for you. I'm not going to repeat them other than to give a special shout out to Vessel Prosthetics. We had an unanticipated change just yesterday. One of the companies that was going to be here is not able to present. And Vessel jumped at the chance and did an amazing job of doing all that is necessary to participate. So thank you, Vessel. We're delighted you're here and appreciate the hard work. So I think with that, we're ready to go. The first presentation today is Focus Technologies. So here we go.
Great. Thanks for having me. I'm Sadek, CEO and co-founder at Focus Technologies, where we've been building this software that would reduce MRI scan time. So if you've ever done an MRI, you would know that you have to stay inside a machine for about 40 minutes or so. We reduced that time to about 10 minutes. Okay, so let's see what the problem is. The problem is right now in the US, we do about 40 million scans a year, but we need about 120 million scans a year. There are a lot of indications that we're not using MRI for because we don't have enough capacity. Stroke, Alzheimer's. There are many different indications that because of the lack of capacity, we're not using this. And this limitation is coming from the fact that we can usually do about 2 patients per hour. We can scan 2 patients per hour, which is because these scans would take about 30 minutes or so. We reduced that scan time to about 5 minutes, which would increase the throughput to about 6 patients per hour. And then that would help us get to that 120 million scan a year. To better understand how this solution actually works, I need to get you to a little bit of a technical aspect of MRI. So when we do an MRI scan, this is not just one scan. You're collecting about 1 gigabyte of data with the MRI machine. And this is a really inefficient process. And when you put all of that together, you get like 1 gig of data, but you only need about 20 megabytes of that because the images that you eventually would get are only 20 megabytes inside. So this says that there's a lot of redundancy in the data collection. So our solution provides a much better, much efficient data acquisition and combines that with more efficient pulse sequences that would reduce that 1 gigabyte data collection to about 250 or 4 times faster. So because when you collect less data, it takes less time. And the way we do this is a combination of our AI and quantum technologies, which are also patented. So let's see how this actually looks like in practice. So here I have 2 images that are practically identical. The only difference is that the one on the right is your standard MRI scan. The one on the left is from a scan that is 4 times faster from our software. And you can see that they're the same. And we actually have validated this by radiologists. We have our FDA clearance for this product, Health Canada approval for this product. And through the FDA clearance process, we did a rigorous assessment to show that not only clinically they are equivalent, but also analytically, from a bench testing point of view, all sort of assessment that we ran indicated that they are equivalent. So how does this look like in the real world? So this is a software as a medical device. You don't need to change the MRI machine. You keep the same hardware, same pipeline. The software would integrate into the workstation and essentially would enable the machine to do faster scans, and the data would be processed through our software, but everything else stays the same. And this would enable hospitals to do scans that are 4 times faster, which would increase their throughput, improve patient experience because you don't need to get stuck inside the machine for 30 minutes or so, and would reduce wait time. Right now, we have our FDA clearance, we have our Health Canada approval, and we're working on getting our first customers, focusing on early adopters. We're focusing on hospitals. The idea is that this would enable hospitals to do more MRI scans, and for every additional scan they do, they make more money. So this actually is part of our ask and needs for our mentor for this program. We need help with basically sales and go-to-market strategy, from pricing, positioning, all of those things. We also are raising a round this year. This would be our second round. We already have raised about $1 million, and this would be our second round. Thank you.
Excellent. Thank you. Very focused and well within the time. Appreciate that. So the first question is from Mark Cohen. Many patients require gadolinium injection. Is this a time constraint that will reduce the improvement in throughput?
That's a great question. So we don't change that part of the timing, but we reduce the scan time. So the time that the patient would spend inside the machine. You still need about 5 minutes to do the injection, prepare the patient, and all those things.
Great, thanks. Second question is Christine Rohan. Christine's getting right to the heart of it. What do payers say about the value of your solution? Or if I paraphrase, well, what do you know? Will they pay the same, and how is this going to fit in?
So who say?
What do payers,
Oh,
the insurers, say
yeah.
about the value of your solution?
Yeah, so from a reimbursement point of view, this is not changing anything. So you already have a code for MRIs. This would be under the same code. You would be using the same code more often.
So let me put a question in that hasn't showed up yet. You and I talked about this. So do you see this becoming the standard for every single MRI? I mean, is the current approach going to go by the wayside?
That's our belief. So right now, I forgot to mention this. So right now, the first version of the software, we're only covering brain, but we have another version that is coming, like we're hoping to ship out fairly soon, which would be full body. And yeah, we're hoping that this would become the standard.
And clarify for us, the FDA, was this a 510(k)? What was the predicate? This is software as a medical device. Tell us about what the FDA approval is for.
Yeah, so it's a 510(k) software as a medical device. And the idea is that what the FDA, like what the FDA is saying is that our images from these accelerated scans have comparable quality images to what standard of care images would actually give you.
Okay. All right. Here's a question from Shane Peng. Have you done a proof of concept or pilot to validate your claims? You alluded to that, but expand a little to answer Shane's
Yeah,
question.
Yeah, so we've done that. We've done prospective pilot studies. We actually have one more coming up fairly soon, where we brought volunteers. We had fundings for some of these volunteers, but this was a volunteer-based study, and we did both an accelerated scan and a standard scan, and we got radiologists to compare the images.
Okay. Next question from Pete Maslowski, one of our longtime mentors, pretty knowledgeable in the area. Talk about the competitive landscape, including MRI manufacturers themselves. What is your real competitive advantage?
Yeah, so yeah, that's a great question. So this has been the biggest problem with MRI, like being slow. So there's obviously competition. GE and Siemens have their own version of this. There are also some other competitor products out there. Compared to our competition, our acceleration rates are higher, better image quality. and better coverage. So let me maybe explain that a little bit more. So with like the product you get from GE or Siemens, this usually only covers their latest MRI machines. And like if you have an MRI machine that is, I don't know, 6 years old, that probably is not going to be covered by this. And not only that, you don't get coverage for a lot of body parts, a lot of MRI sequences. And this is actually feedback that we got from customers that we talk to. So a lot of radiologists that we've been talking to, they've had experience working and using those softwares. Either they were not happy with the quality, the transparency of the AI that they were using, or the fact that this was really limited to specific indications for them.
Okay. So there are a couple of questions here. Callan Voss asked, I think you've been alluding, what are the current MRI software manufacturers doing to improve this already to set you apart? You want to add anything to what you've said?
Yeah, so I would just reiterate that let's say that you have a hospital that has a GE and a Siemens machine. One big differentiator for us is that we are vendor agnostic. And this has actually been a huge feedback from hospitals for us. So having one software with one unified quality, that's a huge value proposition for them. But more than that, this is like you go from 40 minutes to 20 minutes with what you get from GE or Siemens. With ours, you come under 10 minutes. And you don't just get that with, like, say, specific MRI sequences or specific MRI machines. You get it for everything.
Okay. This is a quick question. I know I asked you. Henry Alder asked, will the technology be compatible with all MRI manufacturers' machines?
Yeah. So yeah.
Yep. The answer is yes. Uh, Joseph Bluestein asked, were there any randomized controlled trials showing no difference between your images and the current images? Are they published? So you sort of alluded to what you have, but why don't you go through
Yeah.
that again?
Yeah, so we already have had one. We are having a few more studies coming up fairly soon. And yeah, so we're doing all sort of assessment, like blind randomized testing, like there are two kind of assessment you do. One is on the images themselves to establish the images themselves are the same. Um, there is another layer where you like specifically look at a specific indication. So say for Alzheimer's disease or like dementia or something like that. We also have a study coming up on those specific indications as well.
Okay. So I'm going to ask you a question I asked you during the prep. You are right now, you're selling to hospitals, radiology practices. How do you think about that versus selling to the manufacturers, the machine manufacturers?
Eventually, we want to go to manufacturers. That's definitely something that. But in order to get to manufacturers, we first need to establish that their customers would like to have this. So that's why we're first starting with hospitals that are like their KOLs or something like that, and then that would pave the way for us to kind of have enough evidence to go to, say, GE or Siemens or Philips and make a partnership with them.
Okay. And tell us more about the business model, how you're pricing this. Is this per patient, per use, what are you doing
Yeah.
with that?
Yeah, we're looking at this as a software as a service, and the idea is that we have two pricing model right now. One is pay per use. Basically, for every scan that they would use our software, we would charge a fraction of what they would make for as our fee. There's another version which is a flat fee per month. And the idea is that we're trying to see which one would resonate better with hospitals. Yeah.
Okay. Jorge, if I'm pronouncing it, Cardona asked, what is the main radiological aspect that this software adopts to reduce process time? Yeah, I know you went over that, but just talk about it again to make sure everyone will
Yeah.
understand.
So the main idea is that when you do your MRI scan, the machine is collecting a lot of data. There's a lot of redundancy in the data that it's collecting. So each scan typically is around 1 GB of size. But the images that would get to the radiologist are much, much smaller in size. That's about 20 megabytes. So this is indicating that there is a huge redundancy in the data that we're collecting. The more efficient we make this process, the faster we can make it. And like what we've built is a great recipe for doing that, for achieving that.
Okay, we got time. I'm going to ask the last question. We're coming to the end. This is really good. I understand what you said. I understood it in the prep on the slide. I think there's still some sense. How can I reduce from all this? I'm collecting all these gigs of data down to this much. Convince the audience as your final uh, comment that we're not missing any important information.
Um, so for us, we always go to radiologists because at the end of the day, they are the ones who have to look at these images and see if this is valuable or not. And like we've got amazing feedback from them, but I'll just mention a few. So one of the assessments we did was so we put these images, like the images that you can see in front of radiologists. So you may be asking, okay, so this looks the same to me, but is it the same to a radiologist? And we got that feedback from radiologists as well. And
Okay.
so from some of our radiologists, we're saying, like hearing that if we were not asking them to find distinctions between these images, they would not even be able to tell that these are two different images, which was kind of exactly what we were looking for.
Okay. Great. All right. Thank you. Great job. Great presentation. Thanks for the audience for your active input. Uh, we're ready. So remember, make notes if you're interested with any questions you might have, and if this is something you want to volunteer for. The
Thank you.
second Yep. Thank you. Second presentation is Cobionix.
Good afternoon, everyone. My name is Dan, and I'm the Director of Business Development at Cobionix, and we're here today because we're solving a critical public health crisis in cardiac care access. So we have critical public health access crisis in cardiac care across rural America, and the facts are daunting. Rural adults are dying from cardiovascular disease at a rate 1.5 times higher than their urban counterparts. And the reason for this is because only 9% of physicians practice in rural America, even though 1 in 5 Americans live in these communities. But the physician shortage is only part of the story. Even when rural patients see a doctor and get referred for diagnostic cardiac imaging, which is essential for diagnostic heart conditions, they face a devastating barrier. They must travel 3, 4, 5 hours to the nearest imaging facility. And here's what happens. Of those patients who are referred for transthoracic echocardiograms, over 70% never complete the scan. The travel distance is simply too prohibitive. They don't go and they remain undiagnosed. This disparity translates to approximately 60,000 excess deaths annually from preventable cardiac conditions that could have been caught with timely imaging. We're losing 60,000 Americans every year because they can't access a cardiac ultrasound. Our solution is CODI, a robotic ultrasound system that bridges this geographical barrier. Here's how it works. CODI enables a certified echo tech, a technician, to perform a high-quality cardiac imaging from distances of over 100 miles away. At the patient site, which could be rural or community health center, a non-credentialed assistant simply just positions the patient and the robot. And that's it. No specialized training required. The technician operates remotely using our force feedback controller. They feel the exact same pressures as if they were holding the probes themselves. They see the live ultrasound data and a video feed of the patient. They can perform all the standard cardiac sweeps, the parasternal long axis, A4C, subcostal views, etc., exactly as they would as if they're next to the patient at the bedside. We have built-in safety controls that ensure patient protection throughout the procedure, and the economics are compelling of using the robotic system. CODI provides a 6-month payback period on capital investment for imaging providers. This means that you can extend your catchment area to serve rural populations without the overhead of opening new facilities or relocating staff. And critically, we're not replacing your existing ultrasound equipment. We're leveraging your existing infrastructure, and CODI is a OEM agnostic platform where we can use Philips, GE, Siemens, or any other systems that you might have at your existing facility. We're a bolt-on solution that leverages your technology and clinical workflow. So at the patient site, you only need a lower skilled worker to help position the patient and intake them, not a highly skilled credentialed echo tech. This unlocks a many-to-one care model where one expert sonographer can serve multiple rural or underserved sites remotely, dramatically expanding access while reducing costs in lower volume care settings. At present, we're focusing on refining the user experience, and as you can see here on the far right of the screen, our aim is to make this experience synonymous with how they're currently performing the procedures. We're taking a phased approach to market with our crawl, walk, run strategy. Phase one is in-room assistance, which is launching right now. In this phase, the technician and CODI work side by side in high-volume cardiac imaging centers. By freeing up the technician's hand, CODI increases throughput by 20%, reducing scan time from 50 minutes to 35 minutes. And this enables 2 additional procedures per day, generating an extra $500 in revenue daily. This phase builds trust, validates our technology, and generates immediate ROI for imaging centers. In phase two for remote acquisition, which is our rural access solution, this is the tele-CODI capability that I just described, where technicians operate from a different location. This will require a class 2, this is a FDA class 2 510K clearance, which we're submitting towards the end of 2026. And for phase 3, which is our ultimate goal and vision, think of this as lane assist for your car, and we're evolving it towards fully autonomous driving. The technician still remains involved, but with progressively less manual control as AI assists with pro positioning and image capture. This is years down the road, but we're laying the foundation today. And where are we today? So Cobionix is a company that was founded in 2021. We've received our medical device manufacturing certification back in 2023, making us one of only 3 medical-grade robotic arm manufacturers globally. We have our USPTO patent protecting our robot in Canada, US, and other global jurisdiction. We have ongoing clinical pilot studies in Canada, US, and the UK with signed partner networks. And we've received a large purchase order from the largest cardiac imaging center in the United Kingdom, and we have a strong pipeline of early adopters ready to deploy CODI. We've closed our seed round in 2025 this past year for $3 million, led by Tattletown Tech, a VC that's backed by Microsoft, the Green Bay Packers, and several US hospital systems. And we actually found this investor through the Matter ecosystem, which is really great. We have 18 months of runway. But for 2026, our goals are focused and aggressive. We want to achieve market clearance in the UK first, and then submit our 510K application for the telerobotic ultrasound in the US shortly afterwards. Our second big goal is to complete positive clinical validation data demonstrating equivalent imaging quality in TTE. And then third, we want to sign additional US pilots with forward-thinking cardiac service providers. And then lastly, we want to build momentum towards our Series A round, which we're targeting for early 2027. Yeah, so for the C2MP program, we're looking for forward-thinking imaging networks and cardiac service line leaders that have footprint or is looking to launch telerobotic solutions. Yeah. And then we're looking for commercial experts to help with our go-to-market strategy and strategic guidance for our distribution models and partnerships with OEMs.
Oh, great, thanks. Okay, so there are 2 questions that are sort of technical. I'll read them both. Steve Garko, who applies the gel for ultrasound procedures with CODI or gel not used? Kellen Voss wants to know how much extra time exists currently for specialized echo techs. I'm not sure I quite understand. Is there enough tech time to accommodate the anticipated increased rural demand? So do the gel question quickly.
Yeah, so for the gel question, the robot can apply the gel itself with the fluid line system built in, or a patient side assistant can apply the gel on the patient themselves.
Yeah, so on this specialized echo techs, I think the point here, but correct me, Dan,
yeah,
is you're getting rid of that, right?
We're not getting rid of the specialized echo techs. We're targeting a specific procedure for the heart ultrasound exams, and those are specialized techs. They themselves are, there's a shortage of them, and we're enabling them to increase their throughput by reducing the time it takes to acquire the exams, and also by providing them additional access to rural remote areas to be able to provide the exams.
Then I'm not tracking. Clarify again, the rural, you're not going to have more specialized techs there because they're not in the rural area. That's the point you're making.
Exactly. So we're going to deploy our robot in these rural remote areas.
Yep.
And then someone from a metropolitan area or a major city nearby, they can access that robot and provide that servicing.
So in the short term, you may add to the load. I think maybe that's what this question is about for the existing echo techs. Long term, you want to get to the semi-autonomous where you don't need that, correct?
Correct. Yes.
Okay. All right. Okay. Abe Janis, have you explored the benefits of providing a second probe or third hand for faster imaging in challenging uses like stress echoes?
We haven't explored that, but that's something that's on a roadmap to take a look at.
Okay. And the FDA, you're seeking a 510K, and what will the indication be? What will the label say, and what's the predicate?
Yeah, so there's already a predicate device called the Melody product by Adecotech. They're a telerobotic ultrasound that for their IFU allows the robotic system to hold any probe to conduct the different ultrasound exams, whether it's cardiac, abdominal, obstetric, etc. And we'll be piggybacking off of that IFU. The 510K that's going to be submitted towards the end of 2026. But right now we're focused on the UK market, providing a ergonomic solutions for sonographers.
And so what will the label say for the 510K? What you'll be approved for what?
Will be approved to hold and be an accessory device of different ultrasound transducers to perform, a cardiac exam or abdominal exams. So we'll be adding to the different indications one at a time.
Okay. Let me start. Doug Dettinger. Dettinger or Ottinger? I'm sorry, Ottinger. Cost and service time. What are the cost and service time, the maintenance and calibration for robot arm and remote settings?
Right. So a lot of the installation can be done within a day. There's not much maintenance. We do provide annual servicing for the robot through remote diagnostics and on-site visits as well. We offer the robot, through a CapEx model and a robot as a service model through a multi-year subscription models, and that's pretty in line with what all existing ultrasound systems cost today.
Okay. Joseph Bluestein asked the following question. Sorry, my screen's jumping. Will insurers pay for these, quote, lower qualified echo techs obtained cardiac ultrasound? Or paraphrase, will the insurers pay for cardiac ultrasound obtained by lower quality techs? That's what he's at.
Yeah, so I just wanted to clarify one thing. The techs, they all remain the same. It's the assistants that's in the room with the patient to provide comfort or manual intervention that are the lower skilled workers that aren't as highly credentialed. So they're already existing staff members on payroll already, but we're piggybacking off of the existing CPT codes that already exist for these ultrasound image acquisition exams.
Okay. I want to come back to what, so you weren't on the prep call as your colleague, but I asked him, your opening slide makes a few comments that are probably true. I'm still not clear they're all related. So there's a shortage of cardiologists and ultrasound in rural setting that we understand.
Yeah.
patients are referred, and you're saying a very high percentage of them don't wind up getting their ultrasound exams. Tell me again how you come up with all these preventable deaths and why you think you're solving that. The links don't seem quite as clear to me as the slides seem to suggest.
For sure. Real remote care has always been a challenge to, both Canada and the US. The biggest challenge is the geographic barrier of actually accessing, the nearest facility. So although these patients, they've gone to a physician that have now referred them to get their heart scanned, because of the distance, accessing the nearest imaging facility, some of them simply refuse to go, not getting that conclusive diagnostic of their heart condition or heart disease. And they just let it sit instead of getting it treated.
Okay. I have a long question from Paul Barish that I won't read. I'll summarize it. To obtain 510(k) de novo or PMA clearance, a medical device must include a complete human factor usability engineering data package. Can you share what data you've submitted and how you plan to accomplish that?
Yeah. So we haven't submitted anything to the 510(k) yet. Sorry, to the FDA yet. That is going to be in our roadmap towards the end of 2026.
Okay.
When it comes to the human factor studies, we're working with clinicians to evaluate the use of the robot as well as having patient feedback. And those are ongoing studies that will be getting feedback through our prior to our UK launch that will be feeding into our US 510(k). So it's something that's ongoing developing, but we are working directly with clinicians and the patients to get feedback.
Okay, last question I'll take. We got about 30 seconds. Do you see this becoming the standard and replacing the way we currently do cardiac ultrasound?
So I think ultimately our goal is to fully automate this the ultrasound procedure, just like X-ray, MRI, CT, where there's just a few buttons that you're pressing and then the machine does the rest of the job. So I think the natural progression is going to be ultrasound being automated down the road in the future.
Okay, great. All right, great. Thank you.
Thank you very much.
We are ready for the third presentation, Alto Technologies.
Hello, everyone. My name is Hadi Tahirian. I'm the founder and CEO at Alto, where we provide services for vulnerable people that deserves a safe and dignified home care and not the predatory intermediaries. So our platform actually cuts the burden of administrative and drives measurable saving and focuses on the patient-centric caregiver matching. We actually found out in Canada, especially though, that finding home care is unsafe most of the time for these individuals and very predatory, especially for individuals who are children with disability or seniors. When we actually had a discussion with these families, we found out oftentimes they face caregiver shortages, they have extremely tight budgets, and they have to comply with heavy reporting requirements that comes with some of the funds that they actually receive to obtain home care services at home. And those gaps actually end up creating financial risk, leading to inconsistent and unsafe home care services that they were receiving. Now, our solution delivers predatory-free, vetted home care with policy-aligned workflows and patient-centered matching system that comes with it. Our platform technically brings in the vetted caregivers, a booking system, scheduling system, automates all the what we call the prerequisite reporting that needs to be submitted for them, and also helps these individuals to manage the funds and set up direct billing with any sort of external companies or government funds that they use to remove completely that administrative headache that they have to deal with. So at the end of the day, the families that use Alto, they receive those home care services faster, cheaper, and more cost efficient. Now, we actually currently right now in Canada only We launched our company here in 2023. And since then, we've been providing our services to more than thousands of people. Majority of our customers right now using Alto are children with disabilities and their families, which in most cases, they receive government funding or private insurance funding to receive home care at home. And with them using Alto, we actually have most of our current customers staying with us for more than almost 1.5 years to 2 years at this time. Now, we actually closed our pre-seed round in December of 2025, led by Connexus CVC and 3 other institutional investors, including one from Seattle. Now, with that fund, we're actually working on expanding our services into different markets, including some other provinces right now. Currently, right now, we're in 2 provinces, functioning in 17 different locations right now. And we're also in direct discussion with some of the provincial governments to provide Alto as a white label solution so they can actually deploy some of the fund they deploy through the Ministry of Social Services or Ministry of Health right now. Now, we have a great job. We've done a great job in Canada where we're able to actually separate ourselves from our competitors. And then that actually led into expansion into different locations, as I mentioned before. And currently, right now, we're receiving more than 40% of our current customers through direct referral, either from the users that we had or from these agencies or the fund managers that actually deploy the fund. Now, one thing we actually really focus on right now is having a clear understanding about the US market. We need to understand and explore if our product is even usable in US, if we do have a product market fit, and what that would look like. If it is, then we have to define an actual go-to-market strategy where we can explore how that will look like. And more importantly, if there is a way for us to actually run that white label solution pilot with either a hospital or a private entity that we can use and go through them. And again, that's it for us. We're looking forward to see who will be an ideal person to work with us.
Great. Great. Thanks. Right on time. Nice job. Okay. So I just want to follow up on your last slide because I know when we did the prep, for me, I had a little bit of a challenge understanding because I'm not aware, it's not my area of expertise, of programs like that in the United States. So just to start off, what do you know about potential programs that might be suitable here? Or do you not know anything? Is that why we're starting?
Yeah, actually, last year we were having some discussion with some individuals from that were very familiar with the US market. When they actually looked into our platform, they thought our platform would be an easy solution for the private hospitals to use, excuse me, to move the patients out of the hospital during the recovery time. And I can give you a great example. So an individual goes in for a hip surgery. There's a specific action that needs to happen with that individual. For example, they need to see an OT for a few times. They need to see a physiotherapist, have a nurse there to, comply with some administrative things that they have to do. And then they thought with Alto, the hospital can actually use to preset items for them at home. So instead of the patient recovering in the hospital, they could actually recover at home. So they would actually be able to push more patients through the hospital doors where they can actually have more surgeries, they can have more procedures done as well. I haven't had a chance to actually validate that. And that's why we thought joining this program would be great for us to understand that if that's the possibility.
Okay. So what I'd like to do, I don't have a lot of questions coming in right now. So let's be constructive here. And until they start coming, let you and I engage in thinking about what expertise, I know the goal, what expertise you're really looking for. Do you think it's someone that is on the payer side, someone from a hospital administrator side? Because the things that you just described, I know when I have family members or friends that are in a hospital, the discharge planning from the hospital includes all of that. And it depends whether we're talking about reimbursement that's on a sort of DRG basis or fee for service. All those things are happening. But again, I'm not aware of what I learned from you about the government programs where the government, and maybe tell the audience how the government gives money and the patient has to set up a checking account and everything else. That's a bit different. So talk
Sure.
about that and how that may translate to something here so we can get you folks to really give you the insights you're looking for.
Absolutely. I think I think that was a great thing about joining the program because we're not sure if US is the proper market for us to expand into because of the way the system works. And I think that's where we wanted to get a clear understanding. In Canada, the federal government actually provides a specific amount of money that they can deploy to different provinces, depending on the population and the segment. There's more push for these provincial funding to be directly assigned to the end user, which are individuals with disabilities and seniors. They get to decide how they want to spend it, who they want to hire, and when they want to hire people to provide home care at home. It's a push for that, kind of a pull away from that institutional care here. And then with these funds being deployed, there's a very restrict set of reporting that needs to get submitted on a monthly basis in order for them to be able to obtain the following month funding through those. But they receive a 1 year to 2 year contract at a time. And this is where Alto has been really useful.
Yeah. Okay. Again, I'm looking through the questions, and I think my colleagues are sharing some of the same questions and thoughts that I have. One of them, two questions from Joseph Bluestein. Who is your customer in the U.S.? So what you're saying is that you're not sure. You're here to find out, and
that's right.
We can help you do that. Bill Manganaro has a couple of questions. Is this entirely, the way you told the story, is this entirely focused on persons with disabilities, or it does include senior care? Is it entirely in-home care, or does it include transport?
Excellent. So it's actually, we started with the senior care first, but then we actually started getting asked to do some work with the individuals with disability. When we did the shift, though, we went from having a 90% senior customers, and then within a year, it was actually the other way around. So it was 90% individuals with disability, 10% with seniors. As much as it goes where we provide the care, we've been providing care at people's home, hospitals, institutions, and providing transportation at the same time.
Okay. A question from Gulay Sheikh. I may volunteer you, Gulay, for this. Gulay's from Canada. She's a software AI expert. Have you considered different demographics to scale the software?
Yes, we have. We are at this time. I think the amount of pull we're getting from the individuals with disability is so great that we just shifted all of our resources to that. But yeah, we've been looking into different ways of expanding. Yeah.
And expand a little on how you make money. You
absolutely
as a company.
Yeah. So as of now, we actually just charge 20% of every dollar caregivers make through our platform. So we're on a commission base right now. But with the new, we're hoping that in the US market, though, we actually go into a bit of a SaaS model where we can actually sell our software directly to the hospitals, or an entity that use it, though. I know in Canada, there was an private insurance provider who actually came and talked to us about it too. I don't know what the US market technically would look like, or if it's very similar to what they wanted.
Okay. Shane Peng has a question. What performance KPIs are you hoping to move, i.e. cost, time, etc.?
I think with us, though, we're looking to close our seed round coming up next year. And a big part of our seed round, we really want to have a clear understanding about how much money we need to raise. If we need to go to the US, obviously we need to raise more, or if maybe this is a Canadian solution that we can just explore in Canada or other similar market like UK and Australia.
No, I think the question, which is a good one, you're selling a product and you're getting paid for it. Okay. What do you hope to improve? What's the evidence that you're making a difference? That's what he's asking.
Oh, sorry. So are you asking me like so I don't think I understand the question properly though. Like
KPIs, key performance indicators. What?
correct, I understand that.
Yeah.
So what we look into for KPIs is our GMV. That's number one, and then obviously
your what?
Our GMV.
What is GMV?
So that's like technically our gross revenue that we're looking to first, and then our CAC and LTVs. Those are the three things that we follow up on all the time.
That's not what he's talking about. I think.
Yeah, maybe I don't understand the question. Sorry.
How are you helping people? What's the benefit? How are you going to document the benefit?
Oh, yeah, sorry. Yeah. So we actually reduced the cost of home care for individuals in Canada by 40%. And then we reduce the time it takes for people to obtain home care instead of 4 days to 2 days, and reduce the administrative burden by almost 97%. So those are the KPIs we follow for what we've done.
Okay. Christine Rohan, I may volunteer you for this, Christine. What are the economics of your solution delivery, e.g. direct cost, SG&A, et cetera? People want to hear a little more about the business model. So again, we're talking about a situation that at the moment here in the US, none of us are really clear on that there's a scenario. And I understand you're okay if that's the answer, okay?
Absolutely.
But within your own system anyway, we're still looking to get more at the business. We want you to make money. We're just not quite sure how it happens. So that's what she's asking for, the direct cost, SG&A, how are you going to generate a profit?
That's right. So the direct cost for us is actually extremely minimal. Our software is, so we do have to have two sides of market though. We have our caregivers that we actually onboarded since 2023. I think as a company, we spent less than $2,000 to obtain more than 2,100 vetted care providers on our platform. So the automation is there. There's no shortage of caregivers at the same time. As much as it goes for anything else, everything's automated on our platform. Our direct cost that we have is for 3 other customer support representatives to answer any question how to navigate through the platform.
Okay, great. Well, thanks everyone. This was sort of new to all of us. Thanks for your questions. Thanks for your answers. And hopefully a number of you will sign up and we can help him get the information he's looking for. Great, thanks. All right, we're ready for our third presenter today, which is, fourth, Vessel Prosthetics.
Hello. Thank you all so much for being here and for having us. I'm really excited to be a part of this cohort. I know, as Steve mentioned, we were a last-minute addition, so we plan to make the most of this opportunity, but super, super excited to be here. I'm Sydney. I'm the CEO and co-founder of Vessel Prosthetics. Since my training in biomedical engineering, I've been passionate about prosthetic innovation, so I co-founded Vessel to dedicate my life to it. Prosthetic clinicians, or prosthetists, tell us that poor socket fit, the fit between an amputee's leg and their prosthetic leg, is the biggest problem in prosthetics today. So for our flagship product, my team of engineers and prosthetic leaders have developed an automatically adjusting socket system, empowering amputees to lead healthier, more comfortable lives. Everyone's body changes size day by day and year after year, from diet, exercise, weight fluctuations, even the seasons. But changes in leg size are actually dangerous for folks with a leg amputation like Jane here. Any change in Jane's leg size leads to chafing inside of her socket because although it's custom, it doesn't change size. That chafing can lead to blisters, an infection, and even another amputation. And so Jane's solution right now is to take her leg off and put a sock on several times throughout the day, anytime her leg changes, whether she's at work, her daughter's soccer practice, or the grocery store. When she forgets how many socks to add or when to add them, she goes to her clinic, which spends time that they are not reimbursed for, re-educating her on her sock ply management. And that process alone costs clinics $246,000 a year. At Vessel, we created the KIN automatic volume management system, the only system that transforms any socket into one that automatically adjusts as Jane's leg changes size. As Jane walks, our proprietary technology uses every step and shock absorption to automatically adjust custom panels against the limb as her leg changes size dynamically. With Kin, Jane never has to worry about her prosthesis. The socket adapts to her leg, thereby decreasing discomfort. And Kin does not rely on flimsy sensors, heavy batteries, or expensive motors. Jane only needs to visit her prosthetist when she needs a new prosthetic leg, so prosthetists can spend their time making more legs for more patients, not managing socks. Vessel's and Kin's automatic but mechanical adjustments outperform two competitor categories. Manually adjustable sockets rely on constant manual operation, like if airbags in your car were button operated. By the time you know you need to hit the button, it's too late. And traditional sockets are static, so they don't adjust at all. Not only does Vessel and Kin improve the comfort and fit for amputees, but it's also eligible for two additional reimbursement codes, the adjustable socket code like our competitors, as well as an additional shock absorbing code for the additional feature of Kin. We are at the exciting stage where clinical validation meets commercial traction. We are an FDA registered device, and we've frozen our commercial design. In addition to a cooperative research agreement we have with the United States Veterans Affairs, 5 sites that we're working with, we also have 130 clinics on our commercial waitlist, eager to engage with Vessel and to purchase our Kin system. We also have been in discussions with 2 major distributors, which I can talk about during the question period. And those distributors are very common in the prosthetic space. 2 of the larger ones actually represent about 2/3 of the market, and we have redline distribution agreements that are awaiting execution from those 2 large groups. That is how we will be expanding our sales in the United States. This time last year, we wildly oversubscribed our pre-seed round, which was a goal of $1 million US, and we closed that, as I mentioned, this time last year. So we will be planning a seed round starting in the next 6 months or so, and aiming to close that early 2027. Right now, we are laser focused on launch. We will be selling into 20 key accounts by the end of this year, as I mentioned, supported by those 2 distributors and supported by scalable manufacturing. And then in 2027, we'll shift gears and we'll register with the Canadian and European regulatory bodies in order to scale our device internationally. We will also onboard the remaining 2 distributors in the US to continue to scale sales there. So in terms of working with Matter and this program, we are extremely excited for the fact that Matter is located in Chicago. Chicago is a hotbed for the prosthetics industry, especially with Shirley Ryan Ability Lab being located there. So we're really looking for 2 key types of mentors. The first would be on the scalable supply chain manufacturing and sales side, which I guess is multiple. And so anyone who can help us with that scaling of sales, not just in the United States, but also internationally. I have a short list of sales reps that I'm looking for in the States. And so I'd love support and guidance as I, the current sales team, continue to scale that. And then on the other side, we will be raising a seed round in between $3 to $5 million. And I would love support on that side as well.
Okay.
Thank you so much.
Great. Really well done on short notice. Thanks, Sydney. So I'm going to take the lead. As I told Sydney, I'm a vascular surgeon, so I can vouch for this problem. What I want you to do with my first question is for everyone, including myself, tell us a little more about this sensor and how it actually works, and how did you develop this, and how do I know that it's actually doing what you're saying it's doing?
For sure. So it is a purely mechanical solution. There's no sensors embedded. There's the opportunity to move into electronics later, but we strategically started with mechanical so that it was as durable as possible. What it does is it basically uses a one-way mechanism and a cable. The tension in that cable is used inside of the device in order to translate walking motion from the shock absorber into a mechanical pull on that cable, which contracts the panels against the limb. Once it reaches its tension limit, it slips internally and it can't tighten any further. So it's constantly, slowly but incrementally maintaining a consistent level of compression against the limb via tension in the line.
All right. The first question, from Mark Cohen, what is the incremental cost for the device over the manual and adjustable, and who pays this cost? I think you've touched on that, but answer that directly.
For sure. We sell business to business. So we sell to the clinic sells to the amputee and is reimbursed by insurance. So Vessel does not need to interact directly with payers, which is a huge advantage. We sell to the clinic for $1,750, and then they're reimbursed $5,000 by insurance. The reason for that big markup is because prosthetic clinics are only reimbursed every time they deliver a new device. So they have to bake in the cost of their time into that margin. And so not only do we offer an additional reimbursement, but we also offer better profit margins because we're reducing those follow-up visits that don't get reimbursed.
Okay. Did you talk about IP? Did I miss that?
I did not, but we have a granted patent in the United States with continuation patents pending, and we have PCT applications pending worldwide.
And what is the patent for?
We're patenting all passive automatic volume adjustment. So that really complex but elegant solution in between where it's passive, so it doesn't rely on electronics, but it is still automatic. So there's a couple different ways you can achieve that, and we've patented all of them.
And that patent is granted?
Yes.
And so the company, the other adjustable that's out there, you're different than they are?
We are. So the adjustable ones that are out there are manual. So it relies on the patient to make the change, whereas ours is automatic. So it does not rely on the amputee to make any changes.
Yeah. The question from Doug Ottinger, interesting question. Post-approval initial distribution, how do you plan to engage patients and their families, perhaps social groups or communities or something else?
Great question. We want to work with ambassadors. Paralympians make a lot of sense, but we also want to work with ambassadors that are people that have amputations, but maybe are well known for other reasons, to try and reach a larger group. People with amputations are typically part of the aging population, and so we do want to be able to showcase those individuals. Also, prosthetists, amputees, I should say, are most active in Facebook support groups. And so once we have more patients using our device, we can actually get them to be posting in those groups about their experiences.
Okay. Henry Alder asked, what is the anticipated life for the prosthetic, and how does that compare with existing prosthetics?
We want to match existing prosthetics, and so our device will have a life cycle of 3 years. On average, amputees are replacing their socket every 2.3 years, and that's sometimes just because they need to replace it a bit earlier due to health reasons or health changes.
Okay. Paul Barish asked, it's another detailed question I'm going to summarize, but he's sort of interested in what types of patient-reported data, PROM or PRE, have you collected or will you be collecting?
Yeah, patient-reported outcomes are becoming a huge topic of conversation in prosthetics. They were not historically big, so we're very excited about those. We've been using the standard in the prosthetics industry, so the patient-reported the socket comfort score is one, and then we're also using things like increased step count, increased step distance, mostly patient-reported to start, and then we're looking at doing some studies that have more objective data. Okay.
Interesting question from Shane Pang. Will prosthetists lose money for not adjusting and managing the prosthesis?
That's the beauty of this device, is that prosthetists actually make more profit because they're not reimbursed per follow-up visit. They're only reimbursed for the device. So right now they see patients sometimes 9 times a year, and we can reduce the number of times they see those patients for unnecessary follow-up. You still want them to follow up, just not quite as frequently.
So it's like surgeons. Surgeons want to get paid for the operation. They don't want to see the patients and follow up. Yeah.
It's exactly like that, Steve.
Okay. All right. Interesting. So from the regulatory perspective, you're all set to go. You can start selling. You can start selling
tomorrow if we wanted to.
Okay. Okay. Great. And review again. So what conversations have you had here in the U.S.?
So we have a cooperative research agreement with 5 Veterans Affairs healthcare centers on product validation.
So give us, so the VA is a great population for those that haven't worked in a VA. So what does that mean? What is that CRADA going to do?
Yeah, so the cooperative research agreement for us, it's getting more data in the Veterans Affairs. So I spent Q4 of last year traveling to each of our 5 sites and providing demonstrations, getting a lot of feedback from both their veterans and their care team. And now we're planning to actually have their their amputees wear the device, try it on, and provide feedback that way. And it really, for us, all we have to do is be registered with the FDA, which we are, in order to sell into the VA. But we're using this as kind of the first stage of the sales process as well.
And that's going to be a trial or
Correct.
pilot? How will that work?
More of a pilot. Because they can provide feedback. It's a cooperative research agreement, so it's research and their ability to provide feedback on our device for future iterations.
So how many patients do you know, or you're working that out?
We're still working the details of that. I think we would only need to work with one patient per clinic, which it sounds like few numbers. There's lower populations involved in prosthetic studies, but B, I'd rather start selling quicker.
And is that moving towards a sale to the VA to be their primary vendor?
I wouldn't say primary vendor, because it's kind of like Amazon, where you have a bunch of different prosthetic products that are better for different patient populations. We certainly want to be one of the most used in the VA, and we can do that by selling through the distributors that I mentioned that we've got those red line agreements from.
Let me prompt you and provoke you a little. You are passionate about this. You tell the story very well. Do you believe this is better than anything out there on the market?
Absolutely. Absolutely.
Then why don't you go document that? How would you document that?
How would we document how much better it is? Right now, the things that we want to track for the patient is the improved socket comfort score, because comfort translates to all different kinds of benefits for the patient. And then we also want to document the reduction in visits, follow-up visits for the clinics, because that tells the story for them.
That's my point. And Henry Alder just picked up on, I think, my question. What is your evidence strategy? So I believe you, but I'm a data person. So the VA seems a perfect population to go do a trial, a randomized controlled trial to prove that. And then you have the VA, you are the default, primary vendor. Is that in your plan?
That can be added to the plan. I would say. I would say so. The cooperative research agreement we have right now does not have that sketched out. However, each of the sites individually has indicated interest in working with us on a larger scale.
Okay, great. Listen, terrific. Thanks, Sydney. Well done.
Thank you so much. Thank you for the questions.
Great project, and thanks for jumping in last minute. And I hope we get a lot of mentors sign up. This is really a good project. All right. Excellent. Well, thanks everyone for paying attention and contributing. We're actually right on schedule at 4:45. We're ready for CliniScripts as our last presentation for today.
Okay, excellent. So hi, everybody. My name is Numan Jaffer. Thank you so much for this opportunity. I'm the founder of CliniScripts. CliniScripts is, I founded this company 2 years back. It's an AI scribe company with a focus on mental health. We have about 100 clinicians already using this application. And today I am here to talk about the next phase of CliniScripts, which is focused on autism. Before I go into the presentation, I just want to describe this word ABA, which is Applied Behavior Analysts. These are clinicians who focus on kids with autism. And the main difference between an ABA clinician and a regular teacher is ABA clinicians actually focus on one-on-one training for the kids. So that's a little bit of a context. So today, we'll focus on the next phase of CliniScripts, which is the ABA focus. So let me define the problem. The problem that we are trying to solve here is, I'll start with myself. I am actually a father of an autistic kid. He's 18 years old. For the last 15 years since he was diagnosed, we have been carrying the burden of binders, what we call, for two main reasons. One, it's very, very difficult to find good clinicians, ABA clinicians, and other clinicians that work with kiddos with autism. And secondly, there is a huge wait time as well. So that's exactly the problem that we are trying to solve. There's not enough clinicians who focus on this problem. And families on average have to wait 5 months. 1 in 31 kids now in US actually have autism, and it is growing at about 20%. In fact, every day there are 300 kids who are diagnosed autistic. And so the need for clinicians is growing, and the existing clinicians are stretched. So that's the problem that we are trying to solve. And we call that the burden of binders, because today the way that this works is the clinicians actually have to take a lot of notes, and they typically would take those notes on a piece of paper and give you that as for the development and the progress of the kid. So that's exactly the problem that we want to be able to solve with this next phase of CliniScripts. So the product that we are coming up with, we call it a magical listener. So it is literally on any device. It can work on a phone, on an iPad, or even a laptop. And it listens to the conversation and the session that is happening in such a way that the clinician just focuses on the kid. And that's where the attention is. And it does all the note taking, all the progress notes, everything that is required to have to report back. Very simple to use. And our goal is to make everything paperless and be able to share it not only among the clinicians, but also with the parents as well. So the solution, as I said, will bring different clinicians also together. Although I started, and our beachhead is the ABA, which is the Applied Behavior Clinicians. But there's a lot of clinicians that actually would typically work with an autistic kid, like a pediatrician, a child psychiatrist, an occupational therapist, a physical therapist, even a speech therapist. So our goal is basically to start on the ABA side, focus on the ABA clinics and some schools and schools that actually focus on these kids, and then bring all the other clinicians in so that there is a one unified care that is provided to the kid, which is much better not only for the kid, but also for the parents and for the clinicians as well. So the areas of differentiation that we want to focus on, as I said before, it'll work on any device. It'll be edge computing, meaning that it will not require any Wi-Fi. We'll bring all the data, or what we call the large language models, onto the device or onto the application. It will also do proactive prompting, meaning it will nudge the clinician of what to do if the kid is not responding to prompts. And also there's a major component of parent application, because one of the key things and problems that we identified is that parents are, although they're given all these binders and papers, but they're not kept in the loop of all the progress of what the kid is. It'll be very simple to use. And we also aim to make it hands-free because already the clinician has a lot on their plate when they're dealing with kids with autism. So in terms of where we are, we already have the minimum viable product ready. We already have a couple of clinics signed up here in Canada. We are looking to sign up a few clinics, ABA clinics, or schools in US. Our focus, our moat is basically we already have 30 years of clinical data, and the market, as you can see, is huge with occupational therapists, physical therapists. So just in terms of wrapping up, our milestone is to get to about 500 clinicians. And our ask here today is basically help to get into the ABA clinics market in United States.
Okay, great. Thanks. Open for Q&A. To be clear, you kind of want to expand your product, and you want to try and get access to providers here, correct?
Yes.
Okay. And tell us again the revenues that you have right now and the business model for this.
Yeah, so the business model is it's anywhere from $40 to $100 depending on the usage per license per month. So for these almost 100 clinicians who are using CliniScripts, as I said before, it's an AI scribe. It's a very crowded market, but with our business model, we want to focus on the mental health and now on the ABA space, which is going to be the same model, which is per license per month model, starting from $40 to $100 per month.
Right. So let's try and clarify that for the audience. So I'm not taking care of patients these days, so I don't use a scribe. But it's my understanding there are a number of scribes out there. Yeah. So are you different than the scribe, or you're saying there are no scribes in behavioral health right now?
Yeah, so we are foundation. That CliniScripts is basically an AI scribe company. So we are similar to in that context, but we just focus on mental health.
Okay. And the claims you make about no Wi-Fi and everything else, is that different than any other AI scribe?
So that's the next evolution of where we want to take. Yes. So right now the answer to your question is for this ABA market, because they do a lot of in branch, at home, at school therapies. Wi-Fi might not be available unlike in a hospital or a clinical setting.
Yeah. So who is paying? Is it the ABA that's paying?
It is the ABA clinicians, because we end up saving a lot of time for them in terms of documentation and graphing and reporting.
And they pay per use?
No, they'll pay per month per license. So it'll be anywhere from $40 to $100 per ABA. That's where we are starting per month.
And how are they paid? How are the ABAs paid? How do they make money?
Oh, so they charge by an hour. So an ABA typically would start anywhere from $250 or $300 an hour to charge a school or a parent or whoever, like, even they charge Medicare and other insurance companies as well. So we are billing the ABAs for using our platform, just like an AI scribe company is actually billing the physician.
So some ABAs are reimbursed by payers, you're saying? Some are reimbursed by organizations or institutions, and some by the patients?
Yeah, parents, by the patients, yes. So it's private pay, Medicare, insurance, all three actually pay the ABAs.
So the notion of paying $100 a month for a scribe is to save them time so they can see more patients, right?
Absolutely, yeah.
And do you have data on that? Are you accomplishing that?
Yes, we have on mental health, we have a lot of them in the psychiatrists, psychologists, therapists, counselors. We're starting to get into the ABA space. All of these guys, even physicians, they're all paying anywhere from $40 to $100 per license.
Do you have evidence do they have evidence they're getting a good ROI for what they're paying you, that they're making more money?
Yes, absolutely. They end up, we have a lot of testimonials on our website. They end up actually saving at least a couple of hours per day of doing scribe work.
Okay. And then the next level, walk us through that again, because we're a little rushed at the end. So now you want to incorporate other caregivers specifically for autism, and how will that happen?
Yeah, so our beachhead for autism, so the lead therapist is a BCBA, or it's called an ABA therapist. That's where we're going to lead with. There's a lot of other clinicians, like an occupational therapist, a physical therapist, a speech therapist, a speech language pathologist, and a child psychiatrist. There's a lot of clinicians who actually work with that kid with autism. It's not only the ABA. So we'll start with ABA and then we will expand it to other clinicians as well.
Okay. And now let's come back to what help will be most useful to you for the mentors, because it got a little rushed and I'm not entirely clear. Yeah, so go.
Yeah, so we are already signed a couple of clinics here in Canada who are actually helped us develop this next phase.
Yeah.
It's a minimum viable product. We are in the process of actually deploying it in the next 2 or 3 months, and now we are looking for AB clinics in US.
So you want access to AB clinics.
Yes.
And we'll see. I can't tell you how much of that expertise we have, but strategic partnerships with EMR or others. What would a strategic partnership with an EMR be?
So I'm sure you've heard about Epic and Cerner, right? These are the big boys in the hospital.
Of course.
There are EMR players in the ABA space as well, like Central Reach. There's a couple of them. So that's the second thing that we are looking at, where we could actually get a strategic partnership with an EMR provider in that space. That's the second.
What would be the value proposition?
Yeah, so because we will be the one. So EMRs, as you know, is a collection. They collect all they're the ledger for patient, right? They collect all the data.
Yes.
So we will be that application out there in the field that is collecting and putting that data into their EMR. So their data will become more richer.
So again, I don't work with that, but is it they have their Apple Garden? Is that what it's called? Some Epic Garden. Why can't you just go to their Orchard or whatever it's called? Somebody help me out here in the chat. knows.
You're talking about the marketplace? Is that what you're thinking?
No. Epic mentors. Some of you know more about this than I do. If you want to put it in the chat, there's something called the orchard or the apple orchard or something with Epic. I believe it's a sort of add-ons
Yeah.
that they look at.
Yeah. I'll just wait for mentors to put in, but Epic is not our target market because they focus on hospitals.
Yeah.
These kids, yeah, I mean,
That's why I'm asking. That's the genesis of my question. Yeah.
yeah.
Okay. All right. There are actually no other questions coming in, so we got a couple of minutes. So is there anything that you didn't cover that you want to add here in the last couple of minutes?
No, I think it's we are looking to also raise money this year to be able to actually take this go to the market. We have attended a couple of conferences around ABA. There was a lot of excitement about what we're trying to do. So we just need help to actually get into the ABA clinics. There's a lot of them mushrooming, especially I know in Chicago and New York area that we came across as well. And it's not only the ABA clinics, but even special education schools. All of the schools actually have special ed classes as well. So this could be a big benefit for them as well. And then the last one is pediatricians, right? So there's a lot of pediatricians who are getting into this space as well, not taking care of only the regular kids, but because this thing is growing exponentially, they are expanding into this space by actually hiring ABA clinicians and other occupational physical therapists and speech therapists. So that's the third target market that we want to go after.
Okay. There's a question here from Jorge Cardona. Why offer a classic treatment plan for autism today when neurodivergence currently demands a completely different approach? Jorge, if you want to add something, I'm not sure I completely understand what your ask is. So add a little more, unless Naman, you can answer that.
No, I mean, we are not, this is a platform just to expand. The ABA therapists, they can create their own programs in it. So we are not offering a curriculum or anything of that sort. It's a platform where you can create programs and then you go to the kiddos to help them with things like communication, potty training, independence, all the different things that comes regular to all the kids. So these clinicians actually do one-on-one with the kids, and they will be using this on their device.
Okay. All right. Well, I think we've reached the 10 minutes. So again, thanks, Naman. Thanks, mentors. I think we are at the end of the program. I want to thank everyone for participating today. As a final reminder, I hope that you will all volunteer for all the companies and certainly more than one. And if you put more than one, rank them, my first choice, my second choice, my third choice. We'll take a bit of time and sort of correlate all of this, review the Q&A, and review the volunteers and try and do the best match. We may wind up reaching out to a few folks in particular. I took some notes. You'll also get a survey sometime after today's event on serving as a mentor and other things about this. So I appreciate everybody's time and engagement today. I want to again thank all the folks at the Consulate. I want to thank Olivia and everyone at Matter. And we'll see you all in 6 months for an in-person sort of demo in the fall. Thanks, everyone.